So we left off with our discussion of just basic lead 2 ECGs. We talked about depolarization, we talked about the net vector in the heart, the classic ECG trace. We know what those mean. And to briefly recap, we'll take a look at the cardiac cycle and how they overlap with those individual aspects of the ECG trace. So every cardiac cycle starts with some spontaneous depolarization, and normally, where does that happen normally? Where does that start? Sinoatrial node, absolutely. SA node way up here on the left, highlighted, will initiate the depolarization that spreads across the ventricles. The signal itself corresponds with the P wave, and then as the signal spreads, the contraction and refractory period overlaps with the break between depolarization of the atria and the ventricles. So the signal to contract is what we register on the ECG, and the contraction itself occurs between signals, if you will, during the PQ or the PR interval. The obvious characteristic of an ECG trace is the QRS complex. The signal is relayed from the SA node to the AV node, atrioventricular node, a little, not orange, purple bulb in the middle between the atria and the ventricles. That spreads, that signal spreads through the bundle branches, to the Purkinje fibers, all the way around the ventricles of the heart to squeeze and contract the heart. Again, the signal is what we register. The contraction occurs later or during the interval. And then, a bit of a gray area, the repolarization occurs of the ventricles. We can observe that. We don't observe the atria because it's lost. And we always think of repolarization happening from apex back to base, from the tip back to the top, because we have this upwards deflection. We know repolarization is a negative wave, must be going towards a negative electrode, therefore upwards deflection. There's some argument about that, and we're going to move forward with that interpretation. If you're a cardiologist researching this in the field, there's still active debate today whether repolarization happens in reverse. It seems a little backwards. Our best guess now is that the entire ventricle is hyperpolarized. It's not a directional wave, but something about the characteristic of the entire ventricle repolarizing makes this upwards deflection. It's not typically a retrograde signal. It's not really that important. We don't concern ourselves with details like that. That's the point of another course in grad school. But there is active debate there. We're moving forward understanding that repolarization is backwards. At least that's what causes the upwards deflection. And this whole signal starts all over again, or the cycle starts all over again. 60 times in a minute, however many times in a day for the number of minutes in a day, etc. Now, what if we want more detail? What if we want more detail? We want to know about the inner workings of the heart and different parts of the heart. We don't just want to know how the signal is relayed and that contraction occurs, or how long the signal takes to get between compartments. We want more information. Well, if we want more information, we look in more planes, and a larger number of planes, or a larger number of vectors. So normally we just look diagonally from the upper right shoulder down towards the left. That's one obvious plane where most of the electrical activity collects, but we can look in many different planes by adding many different vectors or many different electrodes. And so the 12-lead ECG, as the name would imply, views the heart through 12 vectors, 12 lines of electrical activity. The classic lead 2 is one vector. It doesn't, like the name might imply, use 12 electrodes, only 10. And we create those 12 vectors from the information of those 10 electrodes. The electrodes are the physical snaps that you connect to the body. Leads, as I refer to them, are the vectors between those electrodes. Normally it's point to point. It's a line drawn between two electrodes. That's what I call a lead. But you don't always need 2 points. Sometimes you can get away with one, and I'll show you that today. We end up making 6 lines in the frontal plane. Frontal plane shown here on the left. And then 6 leads in the horizontal plane through the chest. We also end up having a few that pass over the sagittal plane, the midline plane, just by their vector through the heart moving backwards. But the main focus, the main distribution is frontal and horizontal. So electrode versus lead, bit confusing now, but we're going to clarify it. We'll start with the classic lead 2 ECG setup that lends itself nicely to also generating leads 1 and leads 3. The classic setup with Einthoven's triangle here allows us to collect all the information that we normally receive on lead 2. This is exactly the same as the other slides that we've looked at. Negative electrode on the top right shoulder, positive electrode on the lower left hip, or in that region, lower left ribs. These are both what we call unipolar electrodes. They are negative or positive exclusively. And so there is a firm direction associated with the electrical activity between those two. They have a defined signal or charge. But the left arm electrode, and that's what these acronyms are: right arm, left leg, RALALL. The left arm electrode is bipolar. It can be either positive or negative depending on what companion electrode is generating that vector. If it's the left leg electrode, then it's negative. If it's the right arm electrode, then it's positive. It's the opposite charge to make a usable, comprehensive picture of the activity in that plane or along that vector. And I know last class I mentioned that you'll often use this as a ground, and you can. If you're only concerned about the lead 2, this left arm electrode can be a ground if it's out of the way and usually over bone. In this configuration, where we're collecting information not only on the lead 2 axis, but also for lead 1 and lead 3, the ground would be on the lower right hip, usually on the iliac crest, way out of the way. Not to be confusing. These are the only electrodes in the frontal plane. We have 3 obvious vectors now in the frontal plane. Lead 1, lead 2, lead 3. Pretty clear how those are created. You can see it on the slide. But on the last slide, I mentioned there are 6 vectors in the frontal plane. Those are less obvious. Where did they come from? Using the same 3 electrodes, we can create theoretical vectors. We call these augmented voltage vectors, or augmented voltage leads. They're always preceded by an AV to indicate that they're augmented voltage. Now, what does augmented voltage mean? In the first example, let's say I have readings from the left leg electrode, the lower left electrode. According to the last diagram, I can either use the right arm or the left arm to make usable vectors. But what if I combine them? And I don't mean me specifically integrating the electrical information. The ECG machine will do this. It will take a composite image of the information in lead 3 on the left and lead 2 across the chest, the average information would lie directly in the middle, along the midline between those two real leads. So I'm using the left leg as an electrode, and I'm not using another specific electrode. I'm combining information from two of them to make this hypothetical one in the middle. This is called AVF, the augmented voltage, and I think of it as coming from the foot. It's coming from below. And they're all named for their point of origin. AVF comes from the foot. Uses the left leg electrode and then some composite that's created by the machine itself to create this vector through the midline between the right and left arm electrodes. Well, if we can do that once, we can do it twice and 3 times. We have 3 physical point-to-point vectors, and now we're creating hypothetical vectors. I have AVF off of the bottom. If I choose to go from the right arm, I can combine information from lead 1 across the top, lead 2 obliquely, to make a hypothetical vector directly along the middle of those 2 physical vectors. This one's called AVR, augmented voltage coming from the right arm. It should be no surprise then what the last augmented voltage lead is. The only electrode left that we haven't used to generate one of these hypothetical leads. Coming from the left arm electrode, AVL. AVL from the left arm electrode. So now we're going to put all of this together. How, from only 3 electrodes, do we get 6 vectors? We don't really add anything. We've already described it. I'm going to take each of these orange lines and just move them down. The machine is going to combine them, and when we do that, we get information along these axes. Heart is ideally in the middle, and we can read it in these 3 slices. The 3 augmented voltage leads. Well, if we combine this information with the information we get directly from the point-to-point vectors, lead 1, lead 2, and lead 3, we get a pretty comprehensive view of the heart in the frontal plane. So I've got my electrodes set up here on the top right of the screen. You can see I've added the ground electrode in at the bottom right. It's out of the way. It's not included in the signals being generated. And I'm just taking leads 1, leads 2, and leads 3 that we've introduced 2 slides ago. The blue lines 2 slides ago. I'm going to add them to the orange vectors we just created and create this spiderweb network of vectors. Just from only 3 electrodes, we get this detailed, more than Cartesian plot of the electrical activity going on in the heart. We can look along the major vector, we can look obliquely, we can look at almost any angle we choose in roughly 30-degree increments. The angle between each of these lines is about 30 degrees. Which is enough.
So we have augmented voltage leads?
Yes.
What do you call the ones that aren't augmented voltage? Just leads? True leads? Or?
Yeah. So the augmented voltage leads have a name because we're using a composite from 2 actual leads to create that vector. The other physical ones I would just call leads. Yeah, real leads or true leads. Never really thought about distinguishing them, but yeah, they are just leads. And I'll make it obvious if it's ever on a midterm, for example, that I mean the real ones with the point-to-point electrode connection. You also know which ones are which by the names. Anything with the AV prefix is augmented voltage. 1, 2, and 3 are physical. And maybe physical leads is a better way to describe it. Okay, so to compare to these leads, we add some physical electrodes across the chest and towards the side under the axilla, the armpit, to generate our horizontal plane. View the heart horizontally at a perpendicular plane to the frontal plane we just described. All of these leads are called V leads. They're a prefix V to indicate they're chest leads. I'm not sure what the V exactly stands for. And they're all single electrode leads. So they're like the augmented voltage. We generate a signal from only one electrode, and it projects directly back through the heart. So they're a special electrode, the mechanics of which that make it work I'm not exactly sure, but one electrode generates a signal pointing directly back through the body. And you'll practice placing these when we get to lab, I think it's next week. I think everyone should be able to do a 12-lead ECG. We're going to try to do one during exercise. In the past, it's been really noisy. All the wires pick up a lot of static, and they bounce around a lot, so there's a lot of noise in the signal, and you can't really see it. But we'll try it this year. If not, everyone can do one at rest, at least. And these are harder to place generally than the... No, they're not harder to place. You just need to landmark appropriately. And by landmark appropriately, I mean place V1, V2, V4, and V6, and then V3 and V5 go in the middle. So V1, the very first chest lead, goes at the right border of the sternum at the fourth intercostal space. So you can count down 1, 2, 3, 4. You can count down 4 spaces. Find the border of the sternum right near the midline, and that's where the electrode goes. If you found that, V2 is easy. V2 is at the same level on the left side of the sternum. No sweat. We've got our fourth intercostal space. Let's pop down 1. The fifth intercostal space at what we call the mid-clavicular line, so halfway between the start and end of the clavicle, the mid-clavicular line, which ends up lining up fairly well with the nipple. You can use that as a physical landmark. And women doing this can place it a little bit lower if it's in a sensitive region. Fifth intercostal space, mid-clavicular line, is V4. And then all the way on the mid-axillary line, if you follow that fifth space back, it should curve up a little bit. Mid-axillary line is right underneath the armpit, the median plane between the anterior and posterior halves of the body is where you place V6. Those have pretty well-defined locations. The last two don't. The last two are halfway between, in the case of V3, halfway between V2 and V4. So we've got V4 and V2, and then halfway between, I'll put V3. Same thing goes for V5, halfway between V4 and V6. It might be somewhat overbone. You don't have to be specific with placing them over the intercostal space as long as they're midway between the two reference points is what's important. This gives us our comprehensive picture of the heart. And I'll show you what the combined 12-lead ECG readings would look like. Not the readings, but the vectors, the leads. All put together, we get this complicated, detailed view of the electrical activity in the heart. So I have lead 1, horizontal, lead 3, slightly angled to the right, lead 2, which is our classic lead, the augmented voltage, which are halfway between those, and for complexity's sake, thankfully, this diagram doesn't extend them all the way through. And then the 3D oval in the middle is meant to represent the horizontal plane, V1 through V6. And it looks like it might be a little bit skewed or rotated, what looks clockwise in this case. But that's generally the picture that we get, with the dashed lines being projections outwards towards the back of the individual. And if we place these properly, the chest leads, we get a really nice segmented view of the heart. So V1 and V2 give us a clear picture of the right side of the heart. V3 and V4 are right through the interventricular septum, and V5 and V6, being way over on the axillary line or near the axillary line, give us the left side of the heart. So very detailed, as you can see here. This is the information we get from a 12-lead ECG. Normally, we're used to looking at all the way on the left, the middle line, the first quarter of that line. That's the lead 2 ECG trace, with our P wave, QRS complex, T wave, and that's all we've known so far. Now we're adding lead 1, lead 3, all the augmented voltage leads, and then V1, 2, 3, 4, 5, 6. Very detailed, complicated view. You'll notice not everything looks identical, but they share some similar characteristics. You can tell where the QRS complex is, for instance. It's not hidden in any lead. It certainly looks different. It projects maybe more to the downside in some leads than others, but that tells us about the direction of the electrical activity through that lead. We get information about how the heart is working from that information. Information from that information. So the next set of slides is dealing specifically with how we decipher this. It's fairly long and complicated, but we're going to break it down in a way that I hope is usable.